Hello and welcome to MedCity News' Invest Pitch Perfect contest. Today we are going to be looking at 6 innovative health IT companies, and we are also going to do an audience poll at the end. So I wanted to share some ground rules. 6 startups will present, like I mentioned. Each startup will get 4 minutes to present and 6 minutes of Q&A with the judges. Time will be enforced strictly. The audience will select its favorite startup at the end of the pitches, and then the judges will choose their winner, and the announcement will come next week on medcitynews.com, so please stay tuned for that. Our first judge is Sahil Chaudhary. He's the Managing Director of Cigna Ventures and Strategy. Sahil co-leads Cigna Ventures and helps inform strategic decisions for the parent organization. He joined Cigna in November 2019 and currently serves as a board observer at Ginger and Octave. He previously held board seats at Cogitativo and Solera Health and observer seats at Clear Data and Avalon Healthcare Solutions. Sahil also led the development of a primary care joint venture between Sanitas and BCBS of Texas and served on the board of the joint venture. Previously, he spent 5 years at Healthcare Service Corp, managing corporate development and venture investments for the largest customer-owned health insurance company in the country. Sahil holds a BS in mathematics as well as computer science from New Jersey Institute of Technology. He is an associate of the Society of Actuaries. Welcome, Sahil. Elise Miller-Hoffman invests in promising digital health and life sciences startups in the seed to Series B stage, with a focus on healthcare companies that are solving the pressing problems exposed during COVID-19 pandemic. She's a general partner at Cultivation Capital. She supports the Cultivation Capital portfolio as a board member at Healthy Bites, board observer at Image Mover MD, and former board observer at Narrative DX before the company was acquired in 2020. Elise holds a BA in Spanish Literature and Latin American Studies and an MBA from Washington University in St. Louis. She has been recognized as a St. Louis Business Journal 30 Under 30 awardee in 2018 and was an Olin Business School Emerging Leader Award recipient in 2020. Welcome to you, Elise. And finally, Liz Rocket. She's a director at Kaiser Permanente Ventures. She invests in health tech and tech-enabled services. She leads the fund's impact work and is a leader of its diversity, equity, and inclusion revisioning. She serves on the boards of Big Health and Everytable, is a board observer to Groups, DexCare, and Omada Health, and is a member of the investment committee for Rock Health. Prior to KP Ventures, Liz ran health impact investing for Imprint Capital, acquired by Goldman Sachs. She is a proud alum of Princeton University and the University of California, Berkeley. Welcome to you, Liz. And these are our finalists: care.coach, AthenaX, MiiSkin, MiResource, Elemeno Health, and Stellar Health. The first company to present is MiiSkin, trusted, intelligent teledermatology SaaS platform for millions of patients and their doctors. John Fries, CEO, will be our first presenter. Please go ahead, John.
Within skin cancer, it's estimated that 1 in 5 will develop skin cancer during their life. Missing a malignant skin chain can have severe consequences for the individual, and for other skin conditions, they can be very difficult to control and managing these over time, such as acne, psoriasis, rosacea, and eczema. For skin cancer, early detection is, of course, crucial for successful treatment, when 98% survive melanoma if that is caught early. So MiiSkin is the world's most advanced skin monitoring platform for patients collaborating with their doctor. For the patient, MiiSkin is the most sophisticated mobile app and imaging technology available to check, document, and identify changes in their skin over time. For the doctor, MiiSkin Pro is a telehealth stats platform for any skin condition that need regular follow-ups over time using images. Our unique AI-supported skin monitoring technology covers all elements of skin tracking, For example, for skin areas, we have features such as skin mapping, where we identify lesions and artifacts on your skin, so you can compare these over time. You can do that at home. And for full body photography, we have the automatic skin imaging technology, where you literally take your phone and place it on the table, stand in front of it. Now, AI and machine learning will identify you in front of it and will automate the process of taking these images without the need of any helper. There's a voice overlay that instructs you how to place yourself in the surrounding, so they can standardize these images and take full body images. For close-ups and moles and lesions, we have the mole-sized features where we use machine learning and augmented reality, where we capture a coin as a reference object, and with the coin and the moles and lesions, we will be able to measure the moles and lesions in absolute measurements. MiiSkin does not attempt to automate diagnosis. Instead, MiiSkin empowers people to monitor their own skin and doctors to make better informed medical decisions. We have a compound B2C, B2B subscription model driven by proactive people with skin conditions. You can download our app in the app stores and buy the MiiSkin Premium for $25 in the subscription model per year. And we also send the MiiSkin Pro solutions to healthcare providers in the US for $200 per month per provider.
1 minute.
This is of course HIPAA compliant and FDA classified. We're facing a 12 billion massive digital skin health market, and this is primed for digital SaaS commercialization. We have more than 600,000 downloads and more than 12,000 paying customers been through our system. We have now a solid unit economy and SaaS metrics to support this. We are by far the most trusted and recommended skin health app in the world. More than 160 hospitals and polyclinics support our and recommends our product. We have already 2 US customers using the MiiSkin Pro solution. We have been featured in some of the largest professional publications in the US already, and won a ton of prizes in Europe. We have a management team based in Copenhagen and development team out of Serbia, and have attracted several key opinion leaders across Europe and US. We are asking for $3 million investment ask, $39 million pre-money valuation. With that money, we can grow to 100,000 monthly subscribers and more than 500 monthly active providers using our SaaS platform.
Time is up.
Thank you very much. My name is John Friis, and I'm the founder of MiiSkin.
Great. Thank you so much, John. We're going to go first to Sahil, then to Elise, and then to Liz.
Thanks, John. Very helpful. Just curious on your B2B model, if you could talk about is it dermatologists you're selling to, or other doctors enabling them to sort of help with the conditions, and also what's the value prop from a B2B perspective in terms of either increasing their revenue or some other efficiency?
In the beginning, we were only selling to dermatologists, but we have quite a lot of primary care physicians reaching out to us now, basically because we provide them with SaaS services where they can use a SaaS solution to give their patient the same type of service that Teladoc can offer. So this is a teledermatology or a telehealth service that both doctors can use, so that people don't need to go and have their service from a digital solution like Teladoc. And at the same time, it's also an excellent way to create some loyalty and patient relationship, because we are white labeling and customizing the solution for the hospitals and for the clinics. And basically, this is a very competitive market where patient loyalty means a lot. Did that answer your question?
Yes, thank you.
So my next question is a bit about your marketing strategy. You have this combined B2C and B2B approach. And can you just talk a little bit about some of your marketing strategies and how you allocate between those different channels to reach your end customer of even those physicians or the patients themselves? Yeah,
we call it a self-amplifying marketing loop, basically because it's patient and consumer focused first. We know that downloads, engagement from the patient and consumers brings us more and more doctors. We have we have users and patients coming in and giving us new leads every single week with providers that want to hear about the MiiSkin Pro solution, basically because the patient used this technology before the doctors do. And when we reach out to the doctors, it's basically on a request from their patients. So we use I would say, a consumer first, a patient first, where we use consumerized patterns to create awareness in the market, and hence increasing our inbound leads from the professionals. Currently, we have approximately 1 to 3 doctors and hospitals that reach out to us every single week for a MiiSkin Pro demonstration.
Thank you.
Great, thanks, John. And I think last question for me is, we have seen a number of folks over the years trying to bring something like this, some sort of AI enablement to dermatology. Can you speak to just your theory of the case of what's really going to start to unlock this market and bring this sort of technology capability? Is it about the product differentiation? Is it about clinical community support? Is it something else that you're really focused on trying to unlock this market?
Yeah, that's a really good question. I think the key differentiator here is not to use AI and machine learning for the diagnostic parts. There's been so many technologies, so many companies out there that really want to use images for the diagnostic part of assessing or diagnosing skin cancer or other skin conditions. What we use machine learning, augmented reality, and AI for is actually creating a product that makes it more convenient, easier for the patient to use. Images means a lot for the doctor in their medical decision making, because it basically represents the history and can clarify how therapy is really working. So instead of going into the diagnostic route, we really used the advanced smart capabilities of AI and machine learning to create a product that is engaging and convenient for the patient use at home, instead of trying to diagnose this from patient images alone. We let the doctor alone use the image as sources so that they can make the right decisions for the doctor. We don't take the responsibility away from the patient nor the doctor, but enable that process and this relationship to be stronger with smart technology.
We have about a minute left, a little over a minute left. So if another judge wants to ask a question, please feel free. Go ahead, Elise.
I have one more question. John, could you explain a little bit further your reimbursement strategy in the B2B approach?
Yeah, we have a direct reimbursement strategy. We know there is reimbursement CPT codes already in place for telehealth service within the dermatology field. And we know that some of our doctors are already using those. But since we are not a diagnostic tool, since we're not an assessment tool, we don't have a dedicated for our product reimbursement strategy. But our technology can be used in treatment processes where there is CPT codes.
Thanks.
Excellent. Any other questions from any judge? Nope. Perfect. Thank you so much, John.
Thank you.
For your presentation. And we will continue on with our next presentation that comes from Stellar Health. Stellar Health is a healthcare technology company that helps provider and health insurance companies improve quality and financial performance by prompting providers and their practice staff with recommended value-based actions and real-time payments at the point of care. The Stellar Health platform is a proprietary web-based tool that delivers targeted recommendations designed to meet the new objectives of value-based care delivery models. Daniel Lithwick, Director of Business Development and Strategy, will present next. Take it away, Daniel.
Great. Please confirm when you can see my screen.
Can see your screen, and your time starts now.
Excellent. Great. Thank you. So yeah, as described there, Stellar Health is a value-based care platform that provides actionable insights and real-time rewards to providers and care teams, ultimately to improve patient outcomes and reduce unnecessary utilization. We were founded in January of 2018 by a team of healthcare experts who came from backgrounds of investing, consulting, provider care delivery, but all focused on value-based care. After launching with our first client in MVP in April 2018, we've already built up a significant amount of market traction over the last 3 years. We currently have 300,000 managed lives across 20 states, and we expect that number to reach 500,000 plus by the end of the year. So Stellar's platform and incentive model that we've created is all facilitated by the Stellar application, a point of care workflow tool that delivers a simple checklist of the highest value-based items to be completed for a patient when they're in front of the provider, as well as the additional follow-up or care coordination items that can be completed by care teams when the patient isn't in the four walls of the office. So the checklist itself is made up of value-based actions, each with an associated reward that we call the SVU. That stands for the Stellar Value Unit, an obvious play for those of you who worked at health systems or provider groups on the RVU, the Relative Value Unit. This gets tallied up and paid out to participating medical groups on a monthly basis. As part of our application and services, we complete all payment administration, tracking, and reconciliation. Core to how we integrate Stellar into workflow is a shift in thinking at the practice level from binary metrics to individual steps, each a value-based action that can be completed for a patient. So being a top-of-license platform, every single care team member in a practice can receive a login and ultimately earn rewards for completing workflow. Hello?
We got you.
Sorry, can you hear me?
Yep, we got you.
Okay, somebody muted me. Anyways, put the time back on the clock, please. And so ultimately what we're doing is Stellar drives population health down to like individual patient outcome levels, but even further, it's down to the action level that drives those actions, that drives those outcomes for each patient. So Stellar's platform is gamified and uses the general principles of behavioral economics, but the real goal and benefit of the incentive structure is the ability to reward providers based on the additional time it takes to complete these high value items for their patients, effectively allowing them to spend more time managing care for each patient that comes into the office and ultimately for their full care journey. So our customer is the risk-bearing entity for any managed patient population. So typically these are health insurance organizations, but depending on the ecosystem or the region we're working in, our clients will be health systems, clinically integrated networks, IPAs that take full risk in value-based care contracts and stand to benefit from the type of services we provide. There's 3 financial components to working with Stellar Health on a value-based incentive design to deliver to your participating network of practices. So the first is the SVU incentive pool. Stellar works with the risk-bearing entity to determine a total available pool that can be paid out to participating providers and their staff monthly throughout the year upon the completion of value-based actions. So the total funding amount is based on the patient population as well as the program focus. The pool is never actually characterized as our revenue, and if there are remaining funds at the end of the performance year, it's rolled into the next year or paid back to the client. The second and third components are both tied to Stellar revenue. So Stellar receives a technology and services fee to configure the application, deploy the software, payment administration, and provider performance management. Stellar also receives an at-risk performance fee that's either based on driving performance in agreed upon value-based metrics or receiving a percentage of surplus based on a lower total cost of care. The key ideologies between our pricing model is that the tech and services fee will decrease on a unit basis as we scale any program with any client. And further, Stellar believes in its model such that we're willing to lower the technology and services fee at any scale and shift more of our potential revenue to at risk.
Time's up.
There's that interplay between the two.
I'm sorry, I added 30 seconds back on the clock, which is more than you lost. So your time is up. We're going to go to the judges' questions. Let's start with Elise this time and then go to Liz and to Sahil.
Thank you, Daniel, for the presentation. I found one of the things really interesting about your model in the pool that you talked about. And I'm just curious, is that a tough sell to ask your customers to kind of set aside that money? And if so, do you have sort of a minimum that you require? And does the size of the pool, impact some of the outcomes of your platform? So I'm just curious to hear a little bit more.
Yeah, I'll start to answer that. A lot of good questions there. I'll also let everyone know that my colleague, Maria Reinhold, is also on. So she might want to pop in and answer other questions. But I'll kind of segment out quickly what you said there. So is it a tough sell? I'd say the easy answer there with being transparent also is that it's actually not. It's obviously tough to sell our services in general to health insurance organizations and other health systems, just because, it is a bit of a change from the status quo. So that part is difficult. The actual incentive pool itself is actually more straightforward to them for two reasons. One of them is that a lot of them are already paying or have discontinued care coordination payments that are about the same size purposely, but also tailored to the program that we create, that are about the same size as our SVU incentive pool. Whereas the Stellar SVU incentive pool, not only are we're at risk for performance, so they know that the dollars are going there, we're literally guaranteeing ROI by paying when actions are completed. So instead of the care coordination payments that, often might get tied up at like an IPA or SIN entity level and pocketed as revenue, it's more seen as like, this pool is in an escrow account. I pay these providers in my network when they do things, and if they don't do things, they don't get paid.
The other thing I would add to that is the incentive pool can count towards medical in the MLR calculation, as those dollars are directly improving quality of care. So if there isn't an existing incentive, like Daniel mentioned, it's really impacting the medical cost side of the equation rather than the admin, which makes it a lot more appetizing. And then any unused dollars are returned back to the risk-bearing entity after the performance period. So it's really focused on driving behavior change.
Excellent. I'd love to understand a little bit more about this is clearly a workflow tool. It's conceived of as such that you are trying to help with those broken down steps. But it sounds like you're doing this as a system outside of an electronic medical record or other operating system. Can you just talk about how you help these providers integrate your new tool into their workflow and any innovation you've had to bring to make that happen well?
Yeah, so I'll start with that, and again, Maria, supplement as you see fit. So I'd say for that's a great question, Liz, and as you probably, you're a Kaiser, right? So like it's probably the question we get most from like integrated health systems. The answer is it's really dependent on our go-to-market approach. So if we're working with a payer and they're saying, hey, we want you to help drive performance on these 100 practices in our network that are currently unengaged in our pay for performance program, or not performing, that is a more out of the box. Stellar is worked in concert with the EMR. So like literally as a provider, I will either find a way to import links into the EMR and work it when the patient is in front of me. I know I go to Stellar for I can earn $100 to $150 extra for this patient, and that's where I go. And then it's the top of license go-to tool for medical assistant scheduling wellness visits, schedule transitions of care visits, conduct outreach on screenings, items like that. And then when we actually, the question on integration, when we completely do it, where we find, it's not a one size fits all model, but if we're finding from an information HL7 or FHIR perspective of ensuring everything that gets documented in Stellar and the EMR goes back and forth, as well as having like an actual UI to complete Stellar actions in the EMR, is when our go-to-market is with the health system. So if they're at risk, we're implementing across all lines of business, across 1,000 plus NPIs. That's when we create a coordinated effort to ensure we're fully integrating into the EMR.
The other distinction I'll make is that the Stellar platform really serves as a value-based care performance reporting tool. So while the EMR is great for helping close care gaps, it doesn't show the provider their performance through the same lens the payer views that performance, which ultimately informs any value-based payments that the provider is to receive from the payer. So even in instances where Stellar is standalone to the EMR, there's value in driving providers to that tool so they always know where they stand. One piece I don't think we've mentioned is the fact that Stellar is payer agnostic. So we often have providers using Stellar across multiple payers, and Stellar becomes the one-stop shop to see their performance across multiple payers all in one place, rather than going to various payer-specific, line of business-specific portals.
Thanks, guys. I wanted to talk about competition really quick. Am I right to assume you're competing with the likes of Village and Privia, et cetera, which is a crowded market, and then that combined with consolidation in the provider space just seems like a pretty tough market. So curious, are you selling to providers that may not be a good fit for them? Are you displacing them? How has that worked out for you so far?
I think the first thing to think about is the customer as the risk-bearing entity. And there are many primary care practices out there who don't want to be the risk-bearing entity but want to maintain their independence. We see that a lot with providers who are single doc practices who are single doc and remain single doc for a reason. And in that case, our customer may be the payer, but we're giving the provider some tools and capabilities to be successful in value. And I know Daniel has some thoughts there too.
No, I think that's great. And I think to your question, Sohail, we're obviously very different offerings, but when we talk about, separate the individual providers that you bring into a program like this versus a Privia or an Aledade to the risk-bearing entity. For us, to the risk-bearing entity, we're not solving a problem that's focused on getting a bunch of providers into a contract. It's what is your value-based care priority? Who do you want to perform better? And then how do you get them to act on it? We're an activation company. That is our main focus. And that's how we differentiate with our clients. From a provider perspective, it's that support that we can help them remain independent. We can help them have a better understanding of what they need to do, a more clear definition of what a revenue model can look like as they work with Stellar that we're focused on, as opposed to like aggregating them into a contract, which typically resonates with both sides.
Great. Thank you so much, Daniel and Maria. We'll continue on with our next startup, which is Elemeno Health, an on-demand training and communication tool at the point of care. Elemeno's safety solution helps healthcare systems drive consistency of practice at the front lines, improving patient outcomes at scale while lowering costs. Elemeno delivers bite-sized team communication and training, updates, decision guides, checklists, and video to your frontline staff's fingertips. Content is actionable and trackable anytime, anywhere. Staff can access Elemeno on any device, desktop, or mobile. Arup Roy Burman, MD, founder and CEO, will be presenting next. Take it away, Arup. I can see your screen. It showed. And then
Here we go.
Here we go.
Good?
So I can see it fine. Your time starts now.
Awesome. Hey, so I'm Dr. Arup Roy Burman. I'm a former ICU director at UCSF. I think I understand better than most the pains of trying to get your frontline teams on the same page and keeping them there. That's the problem we solve. We're a B2B SaaS. We deliver real-time training and communication right at the point of care, getting frontline teams on the same page to reduce care variation, errors, and burnout. We have no PHI. You have no IT needed to go all the way to enterprise. This is the biggest problem in medicine today, the gap between what we know as an organization and what we actually do at the bedside. Everything is falling through the cracks. You see, our traditional training and communication modalities are not working. Mind-numbing staff meetings, in one ear, out the other. That's not how we learn. And in the era of COVID, it's unsafe. The blizzards of emails, the posters above the toilet, the binders, the flyers, the SharePoints, staff are overwhelmed. The resulting problem is practice variation and burnout. You know the drill with errors and waste. Now nursing turnover is approaching 20%. Here's Nurse Claire. She's a neonatal ICU nurse. COVID comes around. Claire, we need you in the tents. You need to do the PPE, the swabs, the isolation protocols. If I don't do it right, I'm going to miss a diagnosis. we solve that problem. We give the institution an elegant on-demand training and support solution so Claire can get what she needs, where and when she needs it, whether on the hospital desktop or on her own mobile device when top of mind at dark 100 on a Saturday night. Claire's manager is able to take raw content, whether it's in a Word document or a PowerPoint, or maybe she's captured on a video, one of her rockstar staff or shared from somewhere else. Put that in Elemeno. We transform it into bite-sized nuggets, interactive decision guides, smart checklists, concise how-to video. So Claire doesn't go to email anymore. She sees right here and now, this is what my ED is looking like. Here's the new triage area, and here's how I can pull the information I need on how to swab in the moment. And we've done this for all kinds of high-risk, low-frequency practices, allowing the institution to use their people, their devices, their equipment, their way to drive consistency. And that consistency works. Peer-reviewed results from across the country showing that we've been able to drive COVID readiness, sharing those practices with other hospitals, UCSF using it 100 times a day, driving fidelity in central line practice, reducing infections in half, improving patient safety, and cutting labor costs for training, for the trainer, and improving participation of the trainees. Here's a real one of our clients, 200-bed hospital, sustained reduction in medical errors year over year. They've replaced face-to-face training with a constant drip through Elemeno that can be consumed during your own paid shift or on your own time. Manager efficiency up 25%, staff engagement up, turnover down, saving $5 million a year. We're a B2B SaaS, land and expand model, typical ICU, medium-sized unit, 50 to 150 people, $35K per year. And we've got growing traction, 300% growth in the last 3 years. We're at 7 figures on our ARR. We have no churn. All of our clients are started in department. They are going up to enterprise and some even scaling now to system. We're a $2 billion market from the bottom up. Hospitals are our core, but we're also in ambulatory and post-acute care. And all of our clients are sharing practices, using them to align each other in their system and also to help others in the community. It's about as one, we work together, we learn from each other, don't reinvent the wheel. We've got a team led by doctors and nurses. We know our subject. We're led by former startup founders who know how to build a startup. My right hand here, my COO, led Athena from 200 employees to over 6,000 and 1.1 billion in revenue. We're about elevating quality by empowering the front lines with knowledge and engaging us as an interprofessional team in one community. We invite you to come join us. Happy to take questions. I can't hear anybody.
I was waiting for a prompt, but I think based on our past paradigm, I think I'm up first for questions. Thank you for this presentation. It would be helpful to me to just understand a little bit more about your revenue model. When we've looked at training models in the past, sometimes we've seen it to be a struggle to sort of how do you get this to be a large enough market to sell into. It sounds like you have a thought beyond training. So if you could speak to just the revenue model and the market that you're growing into.
Sure thing. So yeah, we're about, it's about train, sustain, it's about team. So if we're talking about the team, let me just show that over in here. Just one sec. So it's about bringing everybody together. So you traditionally think about having training systems or communication systems, or, you have an enterprise solution. What do you do at your departments? The departments are still relying on that bulletin board in the break room and trying to put all their little nuggets together through analog processes like binders and flyers. We are an enterprise solution for department-based issues. So all of your department managers now have technology at their fingertip so that they can communicate with their teams, with onboarding, with orientation, with updates, with in-servicing, and to be able to drive that local training that they need for their functional work unit to actually work. And they can do this without going through hospital IT. This is directly in their hands. So it's rapid, it's agile. So think of us as a department-based solution, department solution for the enterprise. And so we start in one department, prove value, they tell their friends. It's a viral growth as each manager and educator tells other units to bring the other units on, and then they start sharing content with each other.
Great, we'll go to Sahil.
Thanks. I was hoping for some more clarification on the product. So when you say point of care training, should I think of it as reminders at point of care, or is it,
So there we are in the app. So that what you're saying on a desktop. Here we have updates. The ED at Parnassus at UCSF, they dropped using the emails altogether. So the manager can directly put, this is the latest update. We've closed triage. Hey, we're using Regeneron now. And for Regeneron, how do I decide how I should use it? Boom, boom, I can answer these questions. It's approved or it's not approved. Or it may be that in the moment, I'm doing something high risk, low frequency. I'm looking up my procedures. So I'm in the ED, it's tagging for me. These are my procedures to be aware of. And that, hey, say I'm jumping in for my central line care. I can see in the moment, this is what the images are on how I should be positioning. Here's the text for it as well. So you can use it for communication and you can use it for training, but it's for what I need right then and there in the moment. And it's all tracked on the back end.
Great, we'll go to Elise.
Thank you for the presentation. I'd love to hear about the level of customization that's needed for new clients and any associated services that might come with that and how that impacts your margins as you're scaling.
Sure. So right now, if we look at our margin, we have a significant services component. Our margin is somewhere at about 60%. So if you look at this here, this content is the content that the managers may be putting in that's raw, and it's our job to do that transformation. If it's something that's simple text-based, like the update, those keys are there now that the manager can directly do that themselves without us. If it's a video, that's more complicated, we do that, and everything else in between. Now, that being said, content is shared. So when UCSF did this around COVID, then later what happened was other hospitals, like for example, if we're looking here, El Camino or Marin General, they were asking for help with COVID. And UCSF said, get Elemeno, hey, you can take ours. And then you can take what's already here, 80% done, and change it with that last little step to fit your house. So the more content that comes in, the more of it that's shared, the easier it is for each new client to come on board.
And is that true across the board that health systems are open to sharing that content? Have you found any?
Everybody here is sharing to some capacity. Some are sharing just with their friends and family. Others, like Children's New Orleans as an example, 100% of their content is shareable because they simply believe it's the right thing to do to help your peers. And at the end of the day, that's your marketing. Because if your best practices are adopted around the country, your name is recognized, your referrals go up, your US News World Report ratings go up as well.
Thank you.
We still have about a minute left, so if anyone else wants to ask a question of Arup. Looks like you hit it out of the park. Yeah, Arup. Sorry, I apologize. I realized I mispronounced the name of your company. It's Elemeno Health.
That's right, Elemeno, like the alphabet, to keep it simple. There you go.
Right. All right, we'll continue. Thank you again, Arup. We'll continue with our next presenter, which will be MiResource. MiResource helps connect people to the right mental health care for their unique needs. Mackenzie Drazen, CEO and co-founder, will present next. Please take it away, Mackenzie.
Great, thank you so much. Hi guys, my name is Mackenzie Drazen and I am the CEO and co-founder of MiResource, a platform that helps connect people to the right mental health care for their unique needs. I was introduced to mental health care through my sister Shelby, who struggled with depression, anxiety, and an eating disorder. When Shelby first reached out for help, my family, having had no prior experience with mental health, did not know where to start looking for care. So we asked her pediatrician, who referred us to 3 therapists. The problem was none of these 3 therapists specialized in all of the disorders that Shelby was struggling with, nor were they in network with our insurance. We ran into the same problem when Shelby was hospitalized for an attempted suicide. The hospital referred us to a great residential program that kept her safe from her suicidal thoughts and helped with her depression and anxiety, but they were not equipped to treat her eating disorder. And upon being discharged from the program, Shelby was hospitalized for unstable vital signs due to her eating disorder. These are just 2 examples through her care journey. After going through many types of care, we ultimately failed to find Shelby the right care. And in 2014, we lost Shelby to suicide. I threw myself into learning everything I could about what goes into making a successful care connection. And I realized that there were many mistakes that were made that had nothing to do with Shelby being a difficult case, which she was. The mental health care system is complex, and I can go into these complexities if that's interest, but 3 years after talking to everybody who would speak to me from all corners of the mental health care system, I realized that the reason why no one has figured out how to successfully connect people to mental health care is because of a data maintenance problem. Information on mental health care providers is really hard to keep up to date at scale, which makes it impossible for most organizations to facilitate successful care connections, and why it's so hard for you and I to find care. To make matters even more complicated, patients are often directed to their insurance company's website to find in-network providers. But most of these provider directories were built for both physical and mental health care. And so the filters that work for physical healthcare directories don't let you filter by the right criteria to find the right mental health care, leading you back to square one. This is exactly what we solve for. We collect and maintain all the data points on mental health providers and provide a user with a search designed specifically for mental health care, helping you find the right care for your unique needs. We have spent the last 3 years bootstrapping our company while perfecting our ability to build and engage a provider network so we could solve this data maintenance problem. We proved our hypothesis by licensing our software to 21 university counseling centers on a PEPM basis, building a provider network of 5,000 mental health professionals, of which 80% update their availability every 15 days. And that's just on version 1 of the platform. To date, we have helped connect over 46,000 students to mental health care, and were recently awarded a $1.2 million NIH STTR grant to build and clinically validate a novel machine learning triage model to improve our ability to connect people to care. Now that we have a proven framework, we are going to scale our work with universities and expand into the payer market. MiResource is about to start a paid pilot with a Blue plan and are in the process of developing a suite of software offerings to help streamline our providers' workflows from scheduling to payments, which they have been asking us for. You can think of what we're building like HubSpot for mental health providers. These tools help us increase provider engagement and in turn help us better connect patients to in-network mental health care. Since Shelby's passing, I've spent the last 6 years understanding how the mental health system works and collecting the very best people in the world to join me in solving this problem. We have an incredible interdisciplinary team, advisory board, and investor base, including investors like Tim Draper and Blue Cross Blue Shield of Kansas. This is just the beginning. We truly believe that at MiResource, we can create a world where everybody has access to effective mental health care so that no one ever has to feel the pain that Shelby did. Thank you.
Thanks very much, Mackenzie. I'm really sorry for your loss. I've lost a sibling to cancer, so I feel an instant kinship with anyone who's lost a brother or sister. We'll go straight to questions. Let's start with Sahil, and then we'll go to Liz and to Elise.
Thanks, Mackenzie. Important area, clearly. There's a lot of capital flowing into this space. So the key at this point seems to be to recruit and retain clinicians, and just curious what your experience has been there, and given the number of options out there for clinicians to get paid at this point, what you've been able to do to attract them.
Sure. So the way that we've approached scaling our provider network, which, like you said, it's a saturated market right now, is to go with, so we're really a B2B2C platform. So we partner with the university counseling centers, and the university counseling centers have 20+ year relationships with their local mental health provider networks. And so that's how we've been able to scale the network, is by piggybacking off of the relationships with care institutions that have these long-standing relationships with the providers themselves. And so that's sort of how we've been able to get our foot in the door with the providers. And then we spent a lot of time over the years really involving our provider network in designing the product. So they really like the product because they built it. And so that's how we're able to get in the door, and then they like the product, so they keep using it. And then we've seen a large sort of network effect where then they go out and they tell their provider friends, and those mental health providers also join the platform. So it's, you know, the mental health communities tend to be these little micro communities of providers. And so that's how we're going about intercepting all of those different micro provider communities.
Let's go to Liz. Can't hear you, Liz.
Talking to myself. It's what I do on Zoom. Can you all hear me now?
Yes.
Okay. Hi. Similar, I start from a similar place as what Sahil just articulated in terms of there's so much activity around mental health. A lot of it has been focused within the employer space. They've really been a lot of the folks driving this activity. And you make a great case for just what's broken within how health plans have been trying to provide access to mental health. Can you just talk though a little bit more about, do you see the employers as another driver, or is there a reason that you're taking a different route to market that's not as focused on employers?
Yep, I think, through my sister's case, it really articulated to me, and then through, lots and lots of other stories over the years, is that what gets really complicated and what gets really critical in mental health care is, if you think about the spectrum, right, you've got sort of people who want to improve their mental well-being, but they already have good mental health. And then you have people who are really struggling down to serious mental illness. And in the serious mental illness, once you get into sort of moderate to serious mental illness range, care gets a lot more complicated and a lot more critical to get right. So you're having to juggle not just, a mental health provider or a coach, a therapist. You're having to do IOPs, residential programs, eating disorder clinics, and that care coordination gets a lot more complicated when you're having to juggle a care team. And so the referrals get really complex, but it's still just as hard to maintain that information. So the referrals don't have to be as hard. It's just the data collection piece. And so, within the employer space, you're not really making as many referrals within the complex mental health care that is what we think is really critical to tackle because it's so high impact.
Thanks, Mackenzie, for the presentation.
Just to add one more piece to that, sorry, Elise. Liz, the other component to that is that it's easy for us to go into sort of like more lighter weight connections. But I think we've always focused on the severe mental illness aspect and into the sort of moderate to severe mental illness range because it's the harder thing to tackle. But if you can build a product that can do that, then it's very easy to go up the spectrum as well and to ultimately serve the employer space. But for us, we've found that the fastest way to get to those more complex cases is going through the payer route and the universities.
So thank you, Mackenzie. One of the things I'm curious about, I used to work at a university, so I'm curious how you found the sales process and the sales cycle, selling into universities and some specific needs that they might have. And I noticed on your 5-year projections, it looks like you're trying to hit about 35% of the market in 5 years. And so just want to get a sense of what that sales process looks like and how you plan to scale the company.
Absolutely. That's a great question. So what's interesting is before we even built the product, before we realized that we were even going to start a company, just in trying to learn more about how people go about getting connected to the right care. I was actually an undergrad at the time, so I went to my university counseling center and I asked them, how do you go about connecting students to care? Because, I'd heard that you can only go and see someone in the counseling center for a couple sessions and then they refer you out because they have so much demand for services. And so then I thought, okay, well, there's a care coordinator here that's having to do this on a regular basis. So let's learn from them because they must be the experts at doing this. And I quickly learned that, it's a pretty amazing position that they have in counseling centers called a referral coordinator that you don't really see anywhere else that does just assess what the student's struggling with, refer them out. And in talking to my counseling center, I learned that one of the big problems that they have is really with this data maintenance problem. So then I called up 300 other counseling centers to learn about their process and talk to their referral coordinators. And I learned that across the board, this is a huge problem. And so then we built the software and then I called back up those 300 schools and said, well, I called up a few that to sort of have a nice sampling of different schools as we were trying to learn how all these different counseling centers worked in urban areas and rural areas to really get the feel for the different dynamics. And so then we called 21 counseling centers and they signed up and they've been using the platform. And so now we're going to be opening the floodgates when we release a new version of our product coming in July. We have about 100 schools on the wait list. We just hired the previous director of Duke Counseling Center, and she's also on the board of the AUCCCD, which is the largest professional network for higher education counseling center directors. So Dr. Oakley has been talking to a lot of universities. So, at the end of the day, the counseling center world is very small, and we've had such great success with those initial schools, and they loved it so much. Words just spread really fast. So we're really excited to be able to work with more schools.
Great. Thank you so much, Mackenzie, for your presentation. Next up, we will be hearing from AthenaX. AthenaX is a digital health platform designed to provide integrated cancer care to underserved patients by providing rich real-world data to biotechnology and pharmaceutical. I'm sorry, you can't share your screen at this second. I need to be able to introduce your company before you share your screen. So give me just a moment. Let me go back. By providing rich real-world data to biotechnology and pharmaceutical companies to increase patient engagement and decrease costs for clinical trials, our cognitive behavioral therapy approach will enable us to care for the whole patient. Co-founders Monica Schmid and Jessica Thurmond will present next. And now you guys can share to your heart's content.
Great, thank you.
Let me know when you would like. Yes, I can see your screen, so your time starts now.
Great, awesome. All right. So my name is Jessica Thurmond, and I'll be telling you a little bit more about AthenaX. So everyone here knows someone who has or has had cancer. In 1999, my mom was diagnosed with inflammatory breast cancer. She came from a poor and uneducated background, descended from the Wapdanoyet Sioux tribe. As a result, she didn't know where to start with her treatment pathway, and so she did nothing. My mom died less than a year later at the age of 39. The day my mom passed, she would have started her first dose on a clinical trial. And unfortunately, it is all too common today for patients to view clinical trials as their last option. The pandemic has shown a light on the fact that it's never been more important for the equity of our drug development and distribution of care to be our focus in the industry. In 2018, the FDA published a report of more than 5,000 patients who participated on oncology trials that led to approvals. They found that just 4% were Black and 4% Hispanic, despite the fact that these groups account for over 30% of the population. Concurrently, women have historically been underrepresented in trials, especially women of color, even though we know the mortality rates are higher. Which brings us to AthenaX. We are a digital patient advocate built to be an inclusive, connected clinical trial ecosystem for women with cancer. We provide actionable, evidence-based recommendations for how they can improve their lives as well as their treatment pathway while developing a baseline of performance status to make sure we're putting the right patients on trials. The trial landscape in oncology has never been more competitive regarding eligibility, especially molecular profile. AthenaX will be there for the patient before, during, and after their participation. We want to put the power back in the hands of the patients to tell their own story at every stage of their lives. My name is Jessica, and I am the head of clinical development for AthenaX. I spent the last 10 plus years working in cancer care to bring novel drugs to market, improve patient outcomes, and innovate from the ground up. I attended grad school at Vanderbilt University and executive education at MIT and CSAIL. Monica and I met while working together at Clinipace, an oncology-focused contract research organization where we bonded over these values. Monica?
Thank you, Jessica. I'm Monica Schmid, co-founder of AthenaX and head of commercial strategy. With a career in healthcare focused on business development and an MBA from the London School of Economics, I've been fortunate enough to be at the forefront of groundbreaking healthcare discoveries. This has highlighted the gap between patients and researchers and the information available to make informed health decisions. Before I started in the industry, my grandmother had a tumultuous battle with kidney cancer. Although she was treated at a leading institution, she still lacked a source for real-time treatment guidance, which has driven us to launch a tool that our loved ones would have benefited from. The demand in innovation and investment in healthcare has been growing at a record rate, with the pandemic highlighting the need for improvements in our current system. Drug development is increasingly costly due to the complexities in clinical research, spurring a surge in funding in clinical trial enablement technology, which has doubled over last year. Our B2B SaaS business model initially focuses on our biopharma customers initiating breast, ovarian, and uterine cancer studies with an expansion into additional oncology indications followed by gastrointestinal diseases. The current research model involves disparate systems addressing fragmented components of the patient experience. AthenaX aims to delight patients, providing cognitive behavioral therapy powered by real-time biomarkers, around epidemiological insight, engaging patients throughout their treatment journey. Our comprehensive approach combines multiple pieces of patient data to provide integrative care, combining clinical enablement technology, healthcare navigation, remote monitoring, and cognitive behavioral therapy to promote early detection, treatment, and superior outcomes, ultimately empowering patients to tell their own story. Thank you.
Great, perfect. You finished just on time. So we will go over to the judges. We'll start with Elise, then go to Sahil, and then to Liz.
Excellent.
Thank you for the presentation. I'd love to hear more about how you attract patients to the platform and what that user experience is like for them, so that you create, kind of a trusted environment for them to learn more about, potential clinical trials.
Yeah, absolutely. So we view this as always something that patients can access at any time. And really they can steer what their focus is going to be. So especially, we want to start all the way from patients who believe that they're at risk for potential cancer down the road, even those who have not been able to get any sort of molecular profiling. So for myself, for example, I'm at a risk of over 50% to get cancer at some point in my lifetime. So anything that I can use in an application to help improve my odds are really what one of our focuses are. But then in addition, those are the types of patients that we also want to feed into the clinical trial system, patients who typically may not necessarily have access. So if you're not next to a Stanford or a Vanderbilt or something like that, it's easy when you're there to get that kind of care. But if you are in a rural or urban community, it's much, much harder. And so those are really the types of patients that we're hoping to work with by partnering with nonprofits, as well as community clinics to provide this to patients. If they have interest in clinical trials, then great. But I also think that the road that we hope to go down is in early diagnostics, by continuing to follow patients and analyze their data and see if we can find, really these early stages of what cancer could look like in terms of the, first signs, recurrence, and progression from a real-time epidemiological view.
Thank you.
I know this is likely a longer conversation, but curious if you can hit it, what has led to the lack of female representation in clinical trials, and what specifically you're doing to target the population? And then sort of the second question is, so I get the data play here, just curious that you're also selling to health systems up front, right? Is that the right way to think about it?
So as far as the play of who we're selling to, we're initially working with companies engaged in drug development. We feel that they are the most motivated to attract a diverse group of patients, but we of course do intend to expand to those systems as our second phase of launch.
Yeah, and I can answer the first question. So part of this was because up until about 2000, there were actually no laws that were in place to require additional participation for women. So in 2000, the FDA and government agencies did an analysis of 15 drugs that had recently been approved, and they found that 10 out of 15 of those had much more severe reactions. So in this case, pretty well-known drug had to be pulled from the market, and that was Ambien, because it had serious side effects for women that hadn't been tested. I think that we're also, I think there's a lot of understanding currently about the lack of trust within the communities that are diverse. So our hope is by providing education and really, putting the power in their hands for them to be able to steer their own journey, that this is going to provide more of an easy access into that patients can make that decision and they're able to be in control of their own story in that regards. So I certainly think that it could definitely be a much longer conversation there. But I think that by working with these community and urban clinics, and being able to reach those patients where the doctors don't necessarily have time to even provide some of these insights when you're a community oncologist, is really going to be that point of access for those patients as well.
Thanks. So I think I would love to just hear a little bit more about these services that you're describing beyond just trial enrollment, which I imagine is what your first target market is going to be primarily interested in terms of the cognitive behavioral therapy and remote monitoring that you mentioned, as well as you just mentioned in one of the answers that you might actually be providing some early diagnostic support. What's covering that, or is that somehow covered in what you would like to see pharma pay for? And can you say a little bit more about that model?
Sure. So I think how we think about AthenaX is providing full care across the spectrum. So although when you're in drug development, you're very focused on recruitment and engagement, we're hoping to care for patients even beyond that. And so during the actual trial, we are going to facilitate remote monitoring through wearables and really prevent attrition. That is a big issue for these companies that are engaging in drug development. And as far as the pre-screening process, that's why we're really targeting people who are just diagnosed or may not even have a diagnosis to really let them understand their molecular profiling so they can better understand which trials they will be eligible for.
Yeah, and I wanted to mention too that, out of trials, 85% of them are actually delayed because of the fact that they can't meet their accrual. And that costs on average $600,000 a day that for each day that a clinical trial is delayed. And so we're hoping to be able to fill that market. And I think that also the pandemic, we look at Moderna and Pfizer, some of the first companies that really made a concerted effort to be able to provide more diversity within their clinical trial population. And I think that's a trend that we're going to continue to see this year, even from government officials and grant funding around the cancer initiative. And certainly, I think we're also looking at a surge of patients who have gone undiagnosed and who are looking for ways that they can find out more information and resources in a short period of time, because a lot of patients have avoided going into clinics due to the pandemic. So that's why we really think this is the ideal time for AthenaX to be launched.
Great. Thank you so much, Jessica and Monica, for presenting, and we'll continue with our last presenter of the day, and that is care.coach. The company delivers the future of AI today. The company's digital avatars coach the most complex, high-risk, typically elderly 5% of the US population who account for 50% of all healthcare costs to take better care of themselves and to reduce cost of care for our health insurer customers. The company's human-in-the-loop design allows the company to surpass the limitations of AI while training machine learning models to automate and scale human touch in ways that other companies do not have the data for. So Victor Wang, CEO, will be our last presenter. Victor, please take it away.
So many great companies. Let's sprint to the finish line together, okay? All right.
I can see your screen, so
great.
I will start the time. Go ahead.
I'm Victor, CEO of care.coach. As an immigrant from Taiwan, I saw the impact that social isolation and loneliness had on my grandmother's motivation to recover from her fall and generally to take care of herself. So after finishing my graduate research at MIT in human-machine interaction, I founded care.coach to solve senior loneliness. These days, our capitated health plan customers, including PACE and Medicare Advantage, purchase our avatar and video visits products to enable their most medically and psychosocially complex patients to live safely and independently, staying out of the hospital and ER. We've received over $2 million in cash from sales, $2 million in private funding, and $6 million in non-dilutive awards from Congress and the National Institutes of Health, allowing us to achieve clinical validation, fast growth, and cutting-edge technology with essentially no cash burn in the past year. Now we're shifting gears with a Series A. On the healthcare and operations side, our COO, John, brings us his experience as the chief executive of 5 companies, including a publicly traded healthcare company. And our head of sales, Kendra, was an award-winning clinical program manager at one of our health plan customers before she joined our team. On the technology side, Deepak and Lian exemplify our product and tech chops, including at the PhD level in machine learning. We focus on this top 5% of the US patient population who account for 50% of all healthcare spending. The traditional healthcare system sends these complex people home from the hospital or doctor's office, expecting them to self-manage their multiple chronic conditions like diabetes, heart failure, COPD, their many medications, frailty, falls risk, PT exercises, and behavioral health problems, despite low income, low healthcare literacy, low affinity for technology, and limited family support being barriers to their self-management. No wonder that they end up back in the hospital. Through our products, care.coach serves as a healthcare trained family member, living with each person in their home 24/7. By being there for people, we uncover care needs, coach self-care, and help coordinate care to achieve better outcomes and cost efficiencies. Our primary product is the care.coach avatar, which is the industry's only digital conversational agent that's powered 24/7 by a global team of real humans, enabling truly intelligent, empathetic conversation and relationship development. Care and clinical protocols are automated through our expert system, into which we've programmed thousands of conversational flows and care plans, addressing practically every health risk factor common in older populations, so that we can support our individuals holistically. When COVID hit, our customers helped us to realize that the hardware platform we developed to enable zero tech skill conversational relationships with our avatar turned out also to be the missing link in telemedicine. Our customers now also use our devices for care.coach video visits, our intuitive telemedicine product for the 13 million older Americans who lack the tech skills or tech setup in the home to use mass consumer forms of telemedicine. The patients and health plan members who use our products express extremely high loyalty, as reflected in our plus 77 NPS score. And our health plan executives also recognize the value in how we uniquely combine the best of people and the best of technology to engage complex individuals in ways that no other digital solution can. This allows us to drive industry-leading outcomes as published by universities like UW and Stanford. You can check out care.coach/publications for the journal articles about how we reduce depression or how we reduce loneliness 3 times more than daily nurse visits. Our customers have also published white papers about how the care.coach avatar improves self-care and reduces the need for home nurse visits and ED visits. We're growing rapidly, and the data that we gather from our human-supported conversations and relationships has enabled us to develop machine learning models for automating these conversations and relationships in ways that other companies simply don't have the data for. So if you're in the audience and interested in industry-leading engagement and clinical outcomes, defensible technology, and 7 figures in cash from sales, along with a 3.3x annualized customer growth rate, please get in touch. We're raising a Series A.
Thank you so much, Victor. Right on time too. So we'll go first to Sahil, then to Liz, and then to Elise.
Thanks, Victor. Just to clarify, what when you say human-powered, what does that exactly mean? And then more curious on what the product's actually delivering. Is there there's a care team behind it? Is there access to the care team? What services is the product delivering?
Yeah, that's a great question. Am I able to share like
sure.
70 seconds of video?
Sure, it'll cut into your time, but absolutely, if you think it warrants the conversation.
Okay, it'll help.
I needed a lot of help sometimes.
Bill Langlois is not as mobile as he used to be, and when his wife is away, his only companions are his cats, Boots, Sneakers, and Socks.
Hello, Socks.
Obviously, one of these is not like the others.
Because she's my friend. I talk to her like I talk to my family.
Socks is a healthcare avatar.
She calms me down, especially if I can't breathe. I used to panic. Now she walks me through it.
Whenever the avatar is awake...
So if I want to wake Buddy the dog up, I'm just going to pat him on the head.
That means the camera is turned on, and a health advocate employed by care.coach can see and interact with its users.
And it's going to make sure that they take their medications, that they come to their medical appointments, that they participate in their rehab, that they open the door for our nursing staff.
Can you tell me what kinds of things you do to help Bill out?
Oh, when he is in pain, I call for help.
Socks even entertains.
Help me look for the items as I call them.
It's peace of mind for his whole family.
Oh, I'm like not nervous like I used to be. It may sound silly to you. This thing works. And she brought me out of complete depression when I'm alone. Between my wife and her, I got it made.
Have you taken your morning medication?
This is our other video visits product.
It's giving me a rash. I don't want to take it.
Oh, I'm sorry to hear that. I'll let your provider know so they can help you out. Please excuse me for a moment. Good news. I talked to your provider and your doctor will call you now.
Oh, good. Thanks, buddy.
Annie, it's Dr. Freeman. I got a call from your avatar about your concern with your medication. I heard you're having some kind of rash.
Yeah, do you want to see it?
So that shows how our video visit product integrates with the avatar, but we sell it as 2 separate products. Does that help, Sahil?
Yeah, thanks.
Okay, we'll go to Liz.
Great. I think, and this is actually just queued off of that video. So it seems like you are trying to integrate with care provision. Are you actually providing that care, or are you integrating with a broader care team? Can you just speak a little bit more to the operational aspect of this?
We think of ourselves as a care support member, so we integrate into existing care teams, of which the patient is the most important member. And so some of our function is to support that patient, encourage them, motivate them on top of this social relationship to be more self-efficacious and be more motivated and do all the complex things they need to do every single day for the rest of their lives. And then part of it is to escalate to their care team as necessary. Like, for example, in these capitated health plans with extremely complex members, for example, somebody might be talking with Buddy the avatar dog, watching Seinfeld, saying something like, "Hey, Buddy, I don't know, I'm just trying to distract myself watching TV here. I can't afford to fix my AC, and it's the middle of summer in Boston, and I'm sweltering." And our avatar will actually escalate that to our capitated health plans team, and they'll actually pay $200 to go fix the person's AC to avoid a $2,000 heat exhaustion ED visit. So we integrate into the existing teams, how, depending on how that team operates, or more traditionally we'll escalate to just a primary care physician, or if the plan is taking advantage of family caregivers, we can also escalate to a family caregiver, help the adult child of this person with some respite when they're out of the house doing some shopping, and prevent caregiver burnout. We integrate with any and all members of the care team.
Great, we'll go to Elise.
Thanks, Victor, for the presentation. So one of the questions I have is, who are those competitors that you're coming up against, whether they're more legacy solutions or emerging competitors like yours? And what's kind of getting you across the finish line, with the sales with some of your current customers?
Well, I think of everybody as co-opeters, just to be clear, but the thing that we directly substitute on costs for is traditional human delivered care. But I don't think of it as directly competing, because there's a scarcity of family caregivers. There's a scarcity of RN prepared case managers or care managers. And so what we do is, for the same budget, we'll generally allow those teams to be able to do more. For one stressed out family caregiver, we can support them to do more. The comparison to other technologies is not as direct, because we have real people staffing our avatars 24/7. So there is no real direct comparison between like a chat bot or a social robot or like a virtual nurse on an app. They just simply are not capable of the type of conversations and relationships that care.coach executes every single day. Whereas even though we're human powered, we have a global team powering this avatar. So we're taking advantage of geo arbitrage. And we're also upgrading their skill set through our expert system, into which we've programmed all of these evidence-based and practice-based protocols. So we're highly cost efficient, and we're kind of on a cost basis competing with these digital health solutions, but on a value, power of the relationship, power of the outcomes basis, we're so-called competing with traditional care management, family caregivers, nurse visits to the home. And that's what we reduce the need for.
Thanks. I'm also just curious how you developed the avatar. You talked about how it can, decrease loneliness. And I've heard the same thing even out of, conversational AI. But I'm just curious about the development of that and, how you came to that decision.
Yeah, well, I started the company a long time ago, it seems, back in 2012. And it was called Jerry Joy, because all I wanted to do was bring joy to geriatrics and solve senior loneliness, because it was very difficult for my family in Taiwan, or in Canada, to connect with my grandmother in Taiwan through technology. We were trying to set up Skype and all this. And ironically, I was working on teleoperations research at MIT, and was working on a clinical trial at Brigham and Women's Hospital about teleoperation and telepresence in space telerobotics. I was like, hey, why don't I apply that to solve this problem that not only my family, but 42 million American family caregivers face? And so that's what spawned everything, was this idea that there's actually an abundance of conversational intelligence and empathy and respect for seniors all over the world. There's kind of a scarcity of it here in the US, unfortunately. But if you apply this concept of telepresence, you can connect much needed resources with those who need it. And then you have to solve the problem that there's this fragmentation of the patient experience. You need like 7 or 8 different people to robustly, reliably care for a single person 24/7. And that's a really bad user experience or patient or member experience. And you're talking about, you're doing very private things together, and it's like 7 or 8 different people 24/7. And so the avatar is the engineering solution to that, to enable somebody to build a continuous relationship with a single persona, a single face, single voice, which is synthesized. And we realized that was the missing piece in healthcare. If you can build powerful relationships with people, if you can become their friend, you can become their family, you can drive all sorts of outcomes. And so we built an expert system into which we coded all these coaching protocols, and that's how the company has evolved to this day.
Interesting. Thank you.
Thank you very much, Victor, for that interesting presentation. Now we'll go to my favorite part of the contest is the People's Choice Award. So Walter, who helps us manage all the tech aspects, will share an audience poll. And so the audience can share and pick who they'd like. Please go ahead and start voting. And startups, please sort of plan a victory speech in mind, because we're going to go to you if you're selected. Okay, great. As Walter tabulates the results, I'm going to go ahead and share a few slides with you. First of all, a big thank you to MHIN, the Mid-America Healthcare Investors Network. That has been our partner for a really, really long time. Big thank you to our sponsors, always, JP Morgan, Komodo Health, McKesson Ventures, and the Penn Center for Innovation. And finally, a really big thank you to all our supporters who help us in identifying interesting startups and encouraging them to apply and boosting the voice of MedCity events, HealthBox, Startup Health, and Matter. And I believe we have Walter ready to share the results of the contest. And looks like it is care.coach. So Victor, what do you have to say now that you've captured hearts and minds?
This is amazing. I thought all the entrepreneurs here are building amazing impact.
I think
was I muted? Was I muted the whole time?
No.
You're good now.
Turn on your video because it looks like your video is off. You were not muted the whole time, but.
Oh, okay. But yeah, it's very meaningful. You're all building very impactful, meaningful companies. So this is amazing. Thank you all so much for voting for us. Let's all continue in making our differences in the world.
Excellent. Thank you so much, Victor. Thank you to all the participants and of course the judges. The track winner, like I mentioned, will be announced next week. At 5:45 Eastern, we will have a networking reception with our partner Matter. Laura will put the Zoom meeting information into the chat box. So everyone, please feel free to join the networking session. Matter will have special breakout rooms where you can interact with some of the Matter companies. So again, thank you so much for participating as a contestant, as a judge, and a big thank you to the audience as well. I'll see you soon.